Okay, so welcome to the Alan J Flisher Seminar. We have the seminar every 2 months, and we're delighted to have you here with us. So today, Dr. Roxanne Jacobs is going to be talking to us about her PhD work. So we're really excited to hear this, and it's great we've got Prof. Margie Schneider on the call as well, who's one of Roxanne's supervisors. But let me tell you a little bit about Roxanne before she starts. So she's a research psychologist who works in the area of mental health, violence and injury, and aging and dementia. And she was a researcher in the South African team of the STRIDE project, which ended in 2022. And the project is called Strengthening Responses to Dementia in Developing Countries. Roxanne's work included research on stigma and dementia, elder abuse, and care and support for older persons living with dementia in South Africa. So all really important work and really a fantastic intersection of mental health and violence and injury prevention as well. So much needed work. So sorry, I'm just admitting a couple more people. So Roxanne, welcome. I'm going to pass over to you.
Thank you, Kay. Hello, everyone. First and foremost, thank you for this opportunity to share some of my work. And like Claire said, it's my PhD project. My supervisors were Professor Margie Schneider and Professor Nicholas Farina. And just before I get started into getting into the gist of things, just to acknowledge everyone that was part of this work. It was quite a big team. It was nested within the STRIDE project, and I list everybody's names on the screen, as you can see, and also to acknowledge the funder. It was funded by the Global Challenges Research Fund. So I'm going to start off with some background, and then I'll get into the study design and the methodology that was followed, and then present only some of the key findings, and then leave with takeaway messages, some limitations and strengths of the study, and then look at some recent developments in elder abuse in South Africa, and then future directions. For some background, elder abuse is a serious public health concern that results in death, traumatic injury, pain, and negative mental health outcomes, for example, depression and anxiety. By 2050, the world's population of older adults aged 60 and older will double from 1.4 billion people to about 2.1 billion people, with about 80% living in low or middle income countries. So as the aging population grows, so too increases the risk for elder abuse. In terms of estimations from the World Health Organization, they're talking about 1 in 6 people over the age of 60 having experienced some form of abuse, and 2 out of 3 people living with dementia experiencing some form of abuse within their lifetime. Underreporting is quite a big problem. It's estimated that only 4% of cases are actually reported. And this is due to fear of disclosure, fear of retaliation from the abuser themselves, which is often in close proximity of the individual, and reluctant to disclose because the abuser is often a family member or adult child within the household. And also, not disclosing because they don't not necessarily recognize the situation as being an abusive one. Non-disclosure is a problem amongst people living with dementia for basically it's amplified by limitations in insight or recallability or communication skills as symptomatic of the condition itself. And these realities keep elder abuse hidden, often relying on the self-report of perpetrators to disclose abuse, which is problematic. Rigorous data on the extent of the problem is globally limited, and as far as we know, South Africa has not established prevalence or risk conclusively yet, with very little published on elder abuse, older persons at risk, and people living with dementia as well. With over 60 million people in South Africa, older persons comprise about 9.2% of the population, of which 6.2% is 65 years and older. It's a multicultural country with various belief systems. Older persons are often a key source of support in families, especially families that practice migrant labor practices. They often take care of grandchildren while adult children are away working. South Africa is characterized by high unemployment, high inequality, chronic poverty, and high crime rates, also seen as one of the 3rd highest in the world. And then state pensions provide a valuable and a stable source of income within households. And often women are found to share their pensions to support entire households, adult children and grandchildren alike. So these conditions position older persons as valuable sources of income and reproductive labor within the household. So it provides both opportunities that support well-being and active aging philosophies, where we want to keep older persons within their environment and active within the households for as long as possible. But it also creates opportunities for exploitation and abuse. So in line with the World Health Organization, the South African Older Persons Act defines elder abuse as any conduct or lack of appropriate action occurring within a relationship where there is an expectation of trust, which causes harm or distress, or is likely to cause harm or distress to an older person. So it includes these broad types: physical, emotional, sexual, financial, or intentional, or neglect. It's important to note that the definitions do vary across the globe, and risk for elder abuse also vary across context. For example, in the South African definition, which is in line with the WHO, the key element is the relationship of trust between abused and abuser. So while this definition is broad enough to include all these various types of abuse, it may not capture all forms of abuse within this particular context. Let's define dementia quickly. It's seen as a broad term that is used to describe a collection of symptoms generated by progressive and neurodegenerative conditions that are characterized by a decline in mental ability, memory loss, and executive functioning that are severe enough to impede daily functioning. So it's not a natural part of aging. The onset is quite gradual and goes unnoticed until symptoms become a lot more pronounced in later stages. It's also estimated that there are currently 57 million people globally living with dementia, and since people are living longer, this number is expected to increase to 152.8 million people by 2050. So dementia prevalence is less established in low or middle income countries. There are some estimations out there for the sub-Saharan region, and these estimations range between 2 and 4%. There's very few studies done in South Africa. There's a small localized study in the Eastern Cape that estimated prevalence to be about 11%, and that is for 65 years and older. We also did the STRIDE study, and the findings are coming out very soon, that estimated prevalence at about 12.5%. Some common risk factors for dementia. Okay, let's look at dementia and elder abuse. Some common risk factors that are found globally for elder abuse are high care burden, poor social support, care depression and psychopathology, substance abuse, the health status and functional impairment of both the older adult and the carer, and then cognitive impairment status of the older person. Also, caring for someone living with dementia is physically, emotionally, and financially demanding, and is believed to intensify as the disease progresses over time and into more severe stages. And as self-care increases or functional dependence increases with the progression of the condition. Studies have shown, however, that carers are at risk of abusing when they're struggling to manage more aggressive behaviors in particular. And these often become triggers for more stress, increased carer burden, and risk for abuse. The complexities in detecting elder abuse is quite complex. As said earlier, elder abuse is hidden by both the perpetrator and the older person themselves. And this is because of feelings of fear or shame, or simply not recognizing that the situation is an abusive one, or not knowing what can be done or where to go and get support and get help. Elder abuse is even more complex to detect in case of cognitive impairment, as the individual's capacity is compromised, the ability to recognize as well as disclose abuse. There's also a lot of cultural variations in how abuse is understood. and how it's manifested, and this also complicates its detection. When we're screening for people living with dementia, this is even more complicated as existing tools globally exclude people with cognitive impairment. So where cognitive impairment is suspected and where there is no visible signs of abuse, indirect methods such as screening individuals around the older person becomes critical in detecting possible abuse. So this usually includes potential perpetrators, which for obvious reasons wouldn't want to disclose or incriminate themselves. So this, of course, is a challenge. However, I think it's important to mention that not all perpetrators are equal and that they do range in culpability from premeditated, deliberate acts of exploitation and abuse, and they range to individuals who are genuinely don't have the capacity or incapability of meeting a care need. So in fact, previous studies suggest that carers who are caring for people who are living with dementia specifically, or cognitive impairment, or physical impairment, they are often more open to reporting their frustrations and abusive behaviors and neglect. So we know that research in South Africa on elder abuse and dementia is quite limited. We need to understand the prevalence and risk and fill the evidence gaps to inform adequate responses that support and protect older persons. Since elder abuse is hidden and complex, we also need contextually relevant and culturally appropriate tools to detect or screen for elder abuse. And if we're going to include people living with dementia who are potentially at risk of abusing, we need to use tools and approaches that are non-confrontational, because you want the abuse to be disclosed and support to be accessed. Okay, so let's have a look at what we did. As I mentioned earlier, this project was nested within the STRIDE project. You can see the link on the slide. We can access and to read more about the project itself and find some of its outputs. But the overall aim of the project was to contribute to improving dementia care, treatment, and support systems so that people living with dementia and their families doesn't have to shoulder the excessive cost of taking care of someone living with dementia or risk impoverishment, and also access help and not compromise their own health. So it was quite a big project, and I'll explain now where this project fits into. I know it's quite small on the screen, but I'll take you through all of it. For this study, there were 4 main sub-studies. The first of which was a situational analysis that focused on identifying current and future needs for older persons, people living with dementia, and their families. And I'm not going to present the findings of the situational analysis in the session. These findings will come out in a paper quite soon in a special issue for in the Dementia Journal. But I'll just highlight how the situational analysis informed the 3 studies that I will be talking about today. So we responded to, for this presentation, I'll focus on, the 3 main sub-studies. Out of the situational analysis, we identified the need for measurement, having screening tools that are relevant to the context and appropriate and culturally appropriate. And we also identified the need for data on elder abuse experiences and risk factors. So we responded to these needs by doing a cross-cultural adaptation on the tools identified. I'll take you through those now, and a household survey. So the highlighted area over here, you can see the 3 sub-studies that I'll be unpacking in a little bit more detail. So we can start with the cross-cultural adaptation of the elder abuse screening tool and the caregiver abuse screen, and we'll refer to them as the EAST and the CASE. So we identified these 2 tools. The EAST, which is the elder abuse screening tool, was administered the respondents are older adults, and this looks at financial, emotional, physical, sexual abuse and neglect. Whereas the caregiver abuse screen is where the respondents are carers, looks at caregiver risk to abuse and neglect. And it's what's important about this tool is the questions are phrased in quite a non-confrontational way, and elicits is believed to elicit a lot more positive, honest responses. Okay. The study, like I said, it was part of the STRIDE project. The tools were translated. We had 2 independent forward translators and 2 independent back translations that were done, and then we embarked on some cognitive interviewing. So cognitive interviewing is when we use it's quite an in-depth methodology where we use in-depth interviews to identify difficulties experienced by respondents when they're answering questions, and also to understand some of the content that they consider when responding to these questions. So we use this methodology to identify both in-scope and out-scope interpretations. I'll say a little bit more about that now. But we did these interviews in the Western Cape and Limpopo and finished it just before the pandemic struck. And we did it in 4 languages. We did it in English, Afrikaans, Xhosa, and Sepedi. We looked at older adults and carers, and then the carers and older adults had to be fluent in these target languages to help us test these questions to see whether or not they are actually in scope or out scope. In terms of that, in-scope interpretations are those responses that align with the intended meaning of a question, whereas out of scope is when these responses do not align with the intended meaning. Okay, let's see what we found for the East. For the East, we had about the elder abuse screening tool. We had about 42 participants, 23 carers, 19 older adults. We had an average age of about 69 years old. There were mostly women that participated. The participants for testing the tools, they had no suspected dementia, and all carers provided immediate support to a family member who was living with dementia, either a parent, sibling, or a spouse. So overall, the East, the elder abuse screening tool, well, the participants, they had a general understanding of the concepts for all 4 languages. Concepts like hurt, forced, threatened, those things were quite clear. However, when we assessed how questions were understood and what content participants thought of when responding to these questions, we found that the interpretations included quite the broad range of interpretations when they responded. So quite a broad range of general experiences that had either made them feel unhappy or unsafe, but it wasn't abuse. Common themes you'll see on the screen that were out of scope included events that led to changes in relationships, for example, employment dynamics, household responsibilities, or there were these standalone incidences of rudeness or misunderstandings, or occurrences, for example, someone losing a wallet. So many were out of scope, and it generated false positives for about 8 of the 12 East questions. So the East on its own was generating a lot of false positives, and we couldn't use it as it is. We also found that many of the experiences shared would be abusive if they were in a dependency relationship between the older adult and the carer or the household member. For example, if we had to ask a question about whether the older adult depends on someone else for shopping, and that individual refuses, that it introduces a dynamic of neglect, right, or abuse. But when it's just assistance that's being denied, or where the older adult is self-reliant and this is simply a social favor that's denied, that's not abuse. And so basically the East as it is didn't pick up that dependency relationship, which was crucial to understanding the context of each of the East questions. So the East in its current form had no way of screening for that power dynamic. We found overwhelmingly that the responses to 10 out of the 12 questions were references to crime, robbery, theft, burglary, assault, and so on. So responses were grouped under these themes, as you can see on the screen, and participants talked about fear of crime, knowing someone close who were a victim of crime, or having a victim experience themselves. So other examples of crime, but also spoke about other considerations which didn't affect them themselves, or it wasn't someone they know, but it was yeah, the responses contained some elements of crime. Right. So these examples also overwhelmingly were perpetrated by strangers. So this finding reflects that there's this contention in current elder abuse literature and with the current South African and World Health Organization definitions of elder abuse, because they both articulate that abuse falls within the context of a relationship where there's this expectation of trust between the older adult and the perpetrator. So yeah, in the study, we found examples of strangers who deliberately use deception to gain access to the older adult with the intention of exploiting or harming the individual. We had a lot of examples. One was where a salesperson deliberately built trust with the individual so that they could have the older person sign some forms to purchase some furniture unknowingly and exploit them that way. There was another example. Yeah, a young man was helping an older person at the ATM just so they could get closer to them and then rob the older person of their money. So arguably, yeah, older adults are targeted for exploitation or violence because of their age and assumed vulnerability, which is also, we argue, is a form of elder abuse, and it's also considered in other places of the world as well. Okay, so we see this in literature a lot with financial elder abuse, especially where a stranger builds this trust deliberately to exploit and gain access to property and so on. Yeah, and it's quite relevant here. So currently definitions don't exclude these types of crime and violence, but it doesn't necessarily make it clear that these acts by strangers are actually considered elder abuse. So it's a bit of a gray area. Okay, so in most instances, we found that the translations itself wasn't a problem. The wording was fine. It's just there were some minor changes to the Afrikaans one specifically. But yeah, it wasn't the translations itself; it's the interpretations of the questions itself. We had no changes to the response options, as most understood and accepted the yes and the no binary response. The problem was, however, the interpretation and experience is considered, like I said, when responding to the questions, as it generated many false positives about abuse. We also found that crime was a big factor, and it's a major consideration when we're thinking about and understanding elder abuse in the South African context. So, of course, we had to adapt the East. So what did we do? We added a preface statement about explaining or providing a basic understanding to the participant what is defined as elder abuse in this context, at least by our standard definitions in the Older Persons Act. So we added that to contextualize the questions, and then we added some verification probes for each of the questions to try and reduce the false positives that it's picking up. So for each of the questions, we wanted to establish, we asked if they were comfortable to share an example. If they said yes, they are comfortable to share an example, the interviewer who received thorough training, of course, they had to discern whether or not the example that was provided by the participant actually met the definition for elder abuse or not. And then we wanted to know, we probed further, or who was involved in this particular example, so we could collect more or contextual information about the occurrences. And then we added some new questions on crime perpetrated by strangers. As this was quite a dominant theme in all our responses, we wanted to know if their money or valuables or things have been taken by a stranger or a non-family member or community member where they were a victim of general crime. And if they responded yes to this question, we wanted to know whether or not they felt that they were targeted because of their age, and if this had happened more than once. And then, of course, we added the screening question for the relationship of dependency. The question we added was, are you currently relying or dependent on anyone for meeting your basic needs, such as shopping, preparing meals, feeding, dressing, bathing, and so on? So we could understand the context of the other questions that followed. Okay, the case. The case is, remember, is the caregiver abuse screen, and it assesses risk of abusing. So for this adaptation work, most of the questions were in scope, except for one. The term out of character was interpreted quite differently. When asked if carers often feel if they are being forced to act out of character or do things they feel bad about, most of the responses were talking about the caring roles, the shifts in the caring roles, which is not abusive. So just picking up false positives over there. So they were talking about shifting roles and responsibilities, for example, from being a daughter to a carer, or managing their parents' hygiene needs, and so forth. Carers shared a range of experiences considered when responding to the case questions that were indeed in scope, and we grouped them according to themes of the year. So firstly, a lot of the responses fell under pacify and evade behaviors, either calming the individual down, shifting focus, ignoring so that they can cope, and so on, or being forced to be rough, where they gave examples of having to be aggressive to get things done. And then carers themselves being the recipient of aggression and violence. So we found this is also consistent with literature, aggression, and especially unmanaged symptoms of dementia, aggressive behaviors, often a trigger for reciprocal violence in care dyads, increasing care burden, stress, and abuse. Okay, participants found it quite challenging to express their experiences using the binary options, the yes or no. They found it quite restrictive and perhaps confrontational. So they were quite reluctant to say yes to some of the questions. And we noticed this immediately, because instead of saying yes or no, they would say sometimes, little, really. And when asked about why they responded this way and not stick to the yes and the no, they were saying that the care experience it happens on a spectrum and it changes over time, and they would need to be able to voice it in that way as well. So they would like to respond to it on a spectrum, which includes not, often, little, and so on. So what did we do? We adjusted the wording slightly on question 2 to clarify the out of character, what is meant. The underlined text shows where we changed, minor changes, but it had a big difference in how the question was understood. And then we changed the rating responses so that we could, capture the care experiences more accurately. So we, instead of yes and no, we changed it to never, really, sometimes, very often, and always. So once the East in the case was adapted based on our findings in the cross-cultural adaptation work, we used these two tools in the Stride Household Survey to generate some prevalence estimates on elder abuse, self-reported abuse using the East, and risk of abusing using the case. Let me take you through those very quickly. Okay, checking the time. Okay, The Stride Household Survey, I'm not going to go into too much detail on the methodology. There's a paper coming out soon that describes the how and all the details, but it was based on randomized methodologies. We worked in Cape Town, we worked in the Degale area in Limpopo, and we had about 490 households that in the survey that completed the East and the case. And about 408 of those had sufficient data to complete the 1066 algorithm to identify possible dementia cases. And all those details, I'll go through a little bit of it now, but most of them are in the paper. Yeah. To apply the 1066 algorithm, each household interviewed an older adult and an informant. Older adults had to be 65 years and older, speak one of the 4 languages, and questions were asked about memory, health, and well-being alongside being administered the elder abuse screening tool. For informants had to be 18 years and older. They had to live with or know the older adult best, and also speak one of the 4 languages. And questions were asked about their own health and well-being, household questions, and then questions about the older adult's health and well-being. And of course, the caregiver abuse screen was included in that. There's a lot of variable measures you'll see on the screen. These were all the tools that were used in the Stride toolkit, part of the Stride household survey. And this is the data that we used to understand, do some analysis with the East and the case as well. Just to mention, I'll just maybe go through them quite quickly. For the self-reported abuse, when we did our analysis for the East, we of course included the dementia algorithm, whether they had probable dementia or free of dementia, and then we assessed the functional impairment status. Of course, the self-reported dependency item, the social network scale, and then the neuropsychiatric inventory and questionnaire and dementia severity as well. I just want to note the insight variable. This is something we used as an indicator that we called insight into memory impairment. And we use this to measure the cognitive ability of older adults to actually recall their experiences. And this hasn't been done before, so it's quite novel to this research. In this case, of course, they recall the ability to recall their experiences, in this case, the experiences of abuse. We hypothesized basically that less insight or less recallability shows that there's a decreased likelihood to report elder abuse. So how we computed this, it was a composite variable consisting of both informant and older adult data on perceived memory impairment. So we took data from the geriatric mental schedule that was completed by the older adult, and we took a few items from the CSID, which is the community screening interview for dementia. Yeah, so took those 2 and we calculated perceived memory impairment for both, and then computed the 2 together, and then from that we created a new variable where higher scores indicate poorer insight into memory impairment. In other words, we computed the variable that measure recallability of older adults when reporting abuse to control for that the influence of having cognitive impairment and not being able to disclose or recognize abuse. So in this case, yeah, I'll show you what the findings are. For risk of abusing, we used the ZARAD burden inventory and also the other measures mentioned earlier on. Okay, so let's look at the survey findings for the elder abuse screen. In terms of our sample characteristics, the older adults were on average 74 years old. They were mostly female. I know it's quite small, but I'll just give you a quick summary. They were mostly primary school education and higher. Most were retired, with small groups being economically active. And the dementia status could be identified, like I said, for 408 of the participants, of which 14.5% of the sample unweighted had suspected dementia. severity for what was included in the sample in terms of dementia severity, they were largely mild or moderate. We found that about 10.4% of participants screened positive for elder abuse, and this was the verified responses. If out of interest, we also ran the regional tools response and actually found that it was twice as high. It's just if we're looking at unverified responses, it shows the importance of doing the adaptation work and verifying what individuals were thinking of when they responded to the questions. So while elder abuse was reported more by women than men, the differences were not found to be significant. And the most common forms or types of elder abuse were financial or emotional abuse. And of concern is that almost half of money or valuables or any other things that was taken from the older adult involved strangers or non-family members. 44% of these individuals who indicated that they had an experience where strangers took some things of theirs. 44% of them believed that they were targeted because of their age, and 38% said that it happened more than once. Perpetrators, for the most part, most perpetrators were identified as being a non-family member, but having a personal relationship, and then family members either living in the same home or not living in the same home. So firstly, to note that we found no association reporting abuse in older adults' insight into memory impairment, highlighting that a lack of insight into their own recallability. Lack of insight within the present sample was not associated with reports of abuse. Yeah, so it gives us confidence in our findings. For both our univariate and multivariate analysis, functional impairment of the older adult was found to be significantly associated. Sorry, there we go. In both instances. So, functional impairment is a known risk factor that is linked to dependence and vulnerability. However, the association might be more complex. Also, within the present study, we didn't find, though, that it was significant with dependence because we measured that a self-report item. We measured dementia caseness and dementia severity, and these three things didn't reach statistical significance. So we need to further explore this link, why functional impairment and not all these other comorbidities that's associated with functional impairment. We need to explore this link as, like I said, there doesn't appear to be a high level of uncertainty of the true effect within our sample because we had quite wide confidence intervals. Yeah, I think I'm going to leave it at that. There you go. Let's look at the survey findings for the case. Okay. In terms of our sample characteristics, average age was 47 years old, mostly female again, mostly had primary school education and higher. Mostly participants were unemployed or looking for work or retired, and most lived with older adults and were hands-on carer. Older adults were often either their parent or their spouse. So once we recoded the data into a binary scoring, which is the original scoring for the case, more than half of informants screened positive for risk of abusing, of which 14.3% were identified as high risk. Mostly were female. They were similar across age ranges. They had at least primary school and above education, and mostly were unemployed and looking for work or retired. And they were caring for a family member and more likely to live with the older adult. These were the ones that screened at risk. In our univariate analysis, we found that significant associations between informants were at risk of abusing. what was significant was care burden for functional status of the older adult, need for care, psychiatric symptoms, and dementia severity. We also found that carers of people living with dementia were 4 times more likely to be at risk of abusing when compared to carers of people free of dementia. So subsequently, we entered all the significant variables into our multivariate model, and alongside the informant's age, sex, and education, all into a single model. We found that only neuropsychiatric symptoms and care burden were significantly associated. They were the strongest predictors of risk of abusing. So yeah, the rest were not anymore. Dementia status, dementia severity, and care needs were no longer statistically significant in this model. Right. So nevertheless, what does this tell us? Dementia itself may be less pertinent to the risk of abusing, but rather the associated neuropsychiatric symptoms, which also globally has if you look at risk factors, is a risk for increasing care burden. So that makes sense in that sense. Our sample is, however, small and needs further investigation, but nevertheless, it suggests that we could potentially minimize the risk of perpetrating elder abuse if we supported carers and reduced care burden. I'm looking at time. I want a quick summary, and then I'll go to the last few slides. We found that for the self-reported abuse, that they screened high, as 1 in 10 older adults screened positive. We demonstrated the importance of verification of experiences. We found that perpetrators were mostly strangers, either non-family or family members, but strangers played a big part. And we need to explore the link between functional impairment and self-reported abuse. It's quite complex. For risk of abusing, we found that carers of people living with dementia were 4 times more likely to be at risk of abusing compared to carers of people free of dementia. We found that neuropsychiatric symptoms and care burden were the strongest predictors, and that health promotion or education or support for carers are as important as supporting the older adult in prevention and experience of elder abuse. Just very quickly, takeaway messages. We demonstrated the importance of cross-cultural adaptation work because translation is simply not enough. We also included the crime questions because that is something that really came up in our context. And we added verification of responses, which is something that hasn't been done before, but it helped us minimize some false positives. Self-report abuse, takeaway message there would be, we need to understand the link between functional impairment and increased risk of abuse. And this, of course, can inform the strengthening of health and social care systems. Right. Risk of abusing. Dementia itself may be less pertinent to the risk of abusing, but rather the neuropsychiatric symptoms and the increased care burden. The study suggests we could potentially minimize the risk of abusing if we actually supported carers and reduced care burden. Disclosure of abuse, we found one of the first things that what we noticed is there's a big difference between older adults and carers disclosing abuse. One, is it because of community research setting and the proximity of the abuser? Is it because they were screened by strangers in a community setting? Or is it because they fear consequences of disclosure? But nonetheless, it poses challenges to doing, and it's one of those challenges in doing community-based research. And it kind of shows how elder abuse always remains, or it largely remains hidden. In our study, we found support for some of the contention in the elder abuse literature. It shows that older adults feel targeted because of their age. So with the establishment of that relationship of trust, including engagement by strangers, is deliberate. We found that, yeah, it's quite deliberate with the intention to deceive or exploit. So yeah, we need to ask these questions. and talk about expanding or understanding abuse within this particular context. Broad definitions are good to include various types, but it's not, it has implications when it comes to looking at those local idiosyncrasies and the culture interpretation, which challenges measurement and yeah, persecution and legal consequences. Yeah. We have to remember that elder abuse is evolving, and that yeah, it's changing all the time. The development of cybercrime, social media, our conceptualizations and responses should also be evolving. Here we go. Limitations and strengths. I'm not going to go through all of these. We can talk about this if you have some questions. Go back to that. But just to highlight that some of the strengths of the study it's focused on the verification process that we did when screening for elder abuse in the absence of having a gold standard in measurement. And that we also included people living with dementia, which also hasn't been done before, but that we need to, of course, take caution with interpretation, and because it's a small sample, at least we accounted for recallability and using the inside variable that I described earlier on. And we found that there was no association between that and the reports of abuse. Future directions. It's about recognizing and reporting elder abuse. We're talking about public education, training on ageism, targeted screening at health or social care professionals. Not all perpetrators are equal. So it's about providing support versus the criminalization of carers. Having clear reporting and referral pathways that meets the needs of each situation, which is currently not present. And then reporting the absence of where do we report to if there's no services available. Service development for responding to elder abuse. Often the responses, especially criminal justice responses, are to remove the older person from the household. We need to look at other avenues not to reintroduce trauma or secondary trauma. We need to strengthen criminal justice services and then have a multi-pronged response that includes all those different organizations that are relevant. Health promotion of older adults and carers. I think this one is important, and then I'll wrap up. We promote, the idea is to strengthen those policies that promote healthy aging. South Africa already has a big focus on health promotion and well-being. But is to link both the youth and the aging agendas in doing that. So if we're looking at the connection between functional impairment and elder abuse risk, if we target modifiable risk factors through the lifespan, like smoking, malnutrition, alcohol abuse, hypertension, and so on, we can actually reduce risk in later stages in life. And then, of course, with having good policies and strengthening policies, you need sustainable funding to support those programs that respond and protect older persons. And and more research and surveillance, larger studies, routine monitoring and evaluation of health and well-being. Just to say quickly, there's been some recent developments, which is quite hopeful in South Africa. They've launched the National Elder Abuse Helpline at the end of last year. This has been a big gap that has been filled. Also, the Domestic Violence Act has been amended, where they include definitions like coercive and controlling behavior, which is quite relevant to elder abuse itself, and it broadens existing definitions for domestic violence that includes elder abuse. So these are positive developments in the field. And just to remember, next week is World Elder Abuse Day. We often remember the Youth Day, which is the 16th of June, but the day before, the 15th, is World Elder Abuse Awareness Day. Yeah, so the theme this year would be closing the circle, addressing gender-based violence in older age policy, law, and evidence-based responses. Yeah, that is our STRIDE team that helped collect the data. Thank you. That's all from me. I think you can open for questions. I ran a bit over time there.
Thanks, Roxanne. That was amazing. I actually would prefer you just keep talking because it's just such great work. I know it's really hard to condense a PhD and all these years of work into one seminar. You did a great job with that. And I know you didn't get to everything, your PhD, but it's really amazing work. So congrats to you and the team.
Thank you.
Dr. Jacobs, it's amazing. Okay, are there any questions? I may not see people raising their hands, so you can just unmute and chip in. But while people are thinking, maybe I'll just start off. Roxanne, I was just wondering, you spoke about cultural variations and how elder abuse is understood and manifested. And you did mention it along the way, and I mean, amazing work with those screening tools. But what sort of came up with that in the household survey and in your work with the screening tools? What sort of cultural variations came up?
Well, one example would be yelling and shouting, where yelling and shouting would be seen as a risk for elder abuse, or would be seen as violence. In certain contexts, in other communities, it's normal. It depends on the norms of that particular community in terms of neighborhood safety, community and cultural norms of what the ideas are of how normal or natural intergenerational relationships look like. So that's one example. So what is understood in one particular context as being abusive is not seen as normal activity in other contexts, but it's still being included as a risk, though. Even though it's not experiences of abuse in for certain people, it's still understood as being precursors to escalating behavior. So that's why it's still included in the screening tools for risk, assessing risk to try and prevent. Yeah.
Great, thanks. Really interesting. Anyone else?
Roxanne, I just wanted to ask, just first of all, congratulations, amazing study. I just wanted to ask, I know there are a lot of other PhD students on the call, if you had any tips for getting through a PhD and things that you could offer to share with other PhD students who are busy with their work. I mean, you seem to have done it so effortlessly and all delivered on time, amazing published work, you know, really groundbreaking stuff. What are your tips for other PhDs?
Thank you, Craig. Yeah, forget sleep. Aside from that, I think if you believe in the topic that you're doing, the work kind of does itself. If you understand how your work can contribute to where those gaps are, or at least the potential provides some kind of platform to work from, then it helps you get up that early in the morning or sit late nights. So from the experiential side, I think you have to value yourself, you have to value your work, and just not lose hope. I mean, there's going to be lots of challenges, things are going to change all the time, but that's all part of the process. And it helps knowing that you was in a space where there's lots of support. There's always someone else who's gone through this before you, that you can reach out and just share experiences, and that in itself sometimes just helps you get to the finish line. Yeah.
Great, thank you.
Thanks, Craig.
Thanks, Craig. Great question and great response, Roxanne. And Roxanne's a wonderful resource in our Centre for supporting other PhD students. So thanks for that, Roxanne. I see Lauren's got her hand up. Lauren, do you want to unmute yourself?
Good morning, everybody. I hope you're doing well. So I'm currently an intern psychologist, and I'm doing my internship at a rehab hospital, and we get quite a lot of elderly patients who come in due to various circumstances. And there have been a few times in MDT meetings where, you know, they would describe the circumstances and it would raise a few red flags for me. So I was wondering if, you know, there's some kind of standardized protocol available to screen for these things. I know you spoke about the EAST and the CASE. Are these freely available? Can we use them? Yeah, I just want some sort of guidance on what to do if I do suspect something is going on. Thank you.
Okay. Thank you, Lauren. Currently, there isn't a standard tool. It also depends on the organization you're within. I know within social development, they do have a tool that they're using, but it's never been tested to see whether or not that applies across context. So the EAST itself, we selected this tool because it was originally developed by the Department of Health. But its implementation and its use and people knowing about it and using it, there's not anything published on that. We've consulted some people at national level who knows that this tool was created, but it's never been tested. That's why we took this tool and adapted it and then tested it. And yeah, that's the one we use. So the purpose of doing this was to have it be freely available and then have it, see where it can fill those gaps. So currently there isn't anything official that's being used to screen for elder abuse, especially with older persons where there's no physical signs of abuse. It's important to ask at least the right questions to warrant further investigation. Remember, this was a screening exercise. It's not diagnostic in any way. And there's currently no gold standard in terms of measuring elder abuse globally because of the variations in context and in cultures. So this is something that at least starts to fill those gaps and will be made freely available. Yeah.
All right, thank you so much.
Thanks, Lauren.
Thanks, Roxanne. Is that tool, is it available, freely available now? You know, is it something we can put on our website or?
Yeah, at the moment, yes, it can be put on the website. There's still some work that needs to be done to refine it, but what we've done so far can be made available.
Okay, cool. Thanks, Roxanne. Let's go to Shonela.
Morning, everyone. I'd like to first start with saying congratulations to Roxanne. I think it's amazing for me to see the conclusion of the study, seeing that I was also a part of it as much as I did very little work. So it's quite exciting to see how everything has unfolded. Yeah. So I remember when we were still doing the interviews with the carers, we picked up that there was a lot of frustration when it came to the challenges they were facing with the patients. Sometimes the patients would make some stories up, obviously unintentionally. For example, they'd say they didn't have breakfast, whereas they did actually have breakfast. So they would forget certain things. And yeah, sometimes the things they would say, they're a bit delusional, if that's the right word to use, I mean, for their circumstances. So I think the question I have is, how did you then sort of ensure that the feedback you were getting is not that of the patient incorrectly interpreting the situation that they were in? You know, maybe saying it's abuse whereas it wasn't. And is there maybe a follow-up study that is going to be looking at assistance that could be given to the carers in terms of the frustration and perhaps training on how to deal with unbearable situations that the patients might be depicting when they're looked after by the carers? Thank you.
Thanks, Lunella. And thanks for your contribution to she was one of our researchers that helped with the cross-cultural adaptation work. So yeah, very good question. That's why we also, what makes the study unique, and it's not perfect, there's a lot of limitations in itself, but what we try to do is create a variable that controls for that insight into their own memory impairment. In other words, like I said, we compared the insight into memory impairment or cognitive impairment from data we collected from the older adult and the informant itself, and then came up with a variable that we called insight or recallability to control for that. We reported abuse, we could be confident in our reports of self-reported abuse. So yes, forgetfulness, delusions, those kind of neuropsychiatric symptoms are characteristic of dementia, and it becomes quite difficult and quite stressful for carers as well. And especially when you're assessing abuse, you're listening to, let's say, you, for example, you're a healthcare worker and you're in a clinical setting, speaking to someone who is saying, I wasn't fed today, or my daughter's doing this to me or doing that to me. So we can't rely on screening, especially including people with cognitive impairment. We can't rely on screening purely based on self-report. We need to have other measures in place as well that includes observational tools and interviewing proxies, interviewing individuals around the particular individual in question. So those things still need to be developed. There are a few things out there, but it requires a coordinated response. It requires a lot of training, a public awareness on what constitutes abuse. How do we get to actually understanding that this is a situation that requires further investigation? So that insight variable that we at least included in the study helps control for these kind of biases in doing self-report research with people who have cognitive impairments like dementia. Yeah. I hope I'm answering your questions, Lanella.
Yes, well answered. Thank you so much.
Okay.
Great. Thanks, Roxanne. I know there's a lot of work to be done, but this is a fantastic contribution. So congrats again. And thank you so much for this seminar. It's been really fascinating. I really enjoyed it. And thank you to everybody for joining us and being part of today and being part of the discussion. So enjoy the rest of your week.
Thank you, everyone. Thank you, Claire.
Thanks. Bye, everyone.